Good afternoon and welcome to the Underserved Population Networking event. Today's session is entitled Hospital Discharges and Rural Transition Planning. So we welcome you today for attending, or if you're not able to attend live, that you're listening to the recording. This is Misty Kevich with the HHQI team. Also on our call today from the team is Crystal Welch, Sharon Miller, and we are all RN project coordinators. Also on our team is Misty Dyke and Andrea Lepke that are joining us today. We're excited to get started with this great topic that we know that is very important to your heart. We have a polling question. If you will go ahead and answer, the first polling question is, the primary community you serve is rural, urban, suburban, or other? Just to get a sense of where you primarily serve. While you go ahead and get that connected, and answer your question. We'll just let that up for a few minutes. Well, actually, half a minute. I think today, if you're live, we know that we have a lot of snow and cold throughout our country. I think that's a real avenue, too, of rural versus urban, and some of the pros and the cons with having the inclement weather. Okay, and then we're going to be able to get those answers here in just a minute. We're very excited about the project that you're going to hear about from the University of Montana and as the associate. So we can see that the primary communities that are being served are really rural communities that are of the people that are on this call. Great. So as we turn to the next slide, we're going to go ahead and provide you the next polling question. The next polling question is, what are your top 2 barriers or issues that you find that affect health outcomes for your rural patients? So what are your top 2 barriers? I know the list is probably every one of those, but pick the top 2. And while you're doing that, I'm going to go ahead and introduce our 3 wonderful speakers for the session today. Dr. Joseph Knapp is a clinical cardiologist in Western Montana for more than 29 years. In 1990, he actually pursued a master's degree in public health at the University of Washington with the specific intention of developing a greater fundamental understanding of the processes of healthcare delivery and of the economics of healthcare delivery. He focuses on work on comparative effectiveness in clinical outcome research in the realm of cardiovascular disease. Dr. Knapp currently has a part-time cardiology practice and specializes in advanced echocardiographic imaging and management of patients with end-stage congestive heart failure. He is also the director of the International Heart Institute of Montana Foundation Research Division, overseeing several areas of ongoing cardiovascular research. Craig Ravensluth is PhD and a clinical psychologist and research professor of psychology at the University of Montana, where he directs disability and health research for the Rural Institute on Disabilities. Dr. Ravensluth is over 25 years of experience in research, program development, and evaluation of services for people with disabilities funded through the National Institute on Disability and Rehabilitation Research, CDC, and the Public Health Service. He was awarded a Disability and Health Research Scientist of the Year, awarded by the Southwest Conference on Disability, and the Distinguished Service Award by the National Association of Rehab Research and Training Centers. And also, we have Heidi Boehm, who is the lead clinical and outcomes research coordinator for the International Heart Institute of Montana Foundation. She is an RN and has completed her BSN at the University of Great Falls, Montana, and provides direct patient care as a nurse at St. Patrick Hospital and Health Science Center in Montana. She is responsible for conducting medical and device clinical trials and for oversight of day-to-day operations within the research department. So with the polling questions, and Misty, can you help me with those? I did not actually get to see the results for the polling question.
Yeah, it looks like we had a technical hiccup here, so I just opened the polling question again, and it looks like we've got the results coming through again. It'll be just about...
Okay, no problem. All right. And you know what, I will, once we get the polling questions, I'll make sure I throw that out into chat to give a kind of indication of what are some of the key areas. But at this point, I'm excited to get started and hear what our speakers have to offer. So with that, I'm going to turn this over to Craig. Thank you.
Thank you so much, and thanks for having us. I'm advancing the slide here. I'm Craig Ravensloot. I am a Senior Research Associate here at the University of Montana. You may notice from the slide that I'm listed second here. Tom Seekins is our Principal Investigator and Lead Investigator on this project, and unfortunately Tom is somewhere at 35,000 feet over the Atlantic Ocean right now and wasn't able to participate with us today. So I'm pinch hitting for him just a bit. So I want to acknowledge our funders. The research was supported in part by a grant from the Patient-Centered Outcome Research Institute. While PCORI has supported the work, the opinions expressed here are those of the authors and not necessarily those of PCORI itself. So by way of kind of overview, what we want to do today is cover just briefly some issues around rural America and rural health issues that may be familiar to some of you, introduce the rural transition issues that we're looking to address, and then talk about our patient-centered research and development methods that we've implemented, including a model of enhanced discharge and rural transitions planning and implications for the rural healthcare systems. Rural America is a diverse and changing place. Approximately 20% of the population lives on nearly 90% of the land. There are broad cultural differences across these geographic areas. However, a shared characteristic involves inequitable distribution of and access to societal resources in many of these rural areas. This graphic shows healthcare professional shortage areas in the U.S. The deeper the red, the greater the shortage. Many are in rural counties. The low population in large geographic areas conflicts with market strategies for providing health care and medical services. Research has shown that rural residents experience a rural morbidity and rural mortality penalty with higher rates of both relative to their urban counterparts. This graphic shows the distribution of home health agencies in rural areas. The deeper the red, the greater the gaps. White areas are metropolitan counties. For home health agencies, patients are dispersed and travel time reduces service efficiencies, leading to greater service gaps in many areas. You may also face barriers to securing a written plan of care where there are no physicians. Which brings us to rural transitions. Many rural health providers, researchers, and advocates have come to see discharge from a regional hospital to a small town or rural community as a point at which rural health care disparities are most apparent. For St. Patrick Hospital here in Missoula, Montana, this involves over half of all of the patients that are treated. Discharge planners, unfortunately, are often unfamiliar with the services and resources available in outlying areas. So to help flesh this out just a little bit, a case example from some of our preliminary work on this project, this is a patient from a community that's 3 hours driving distance from Missoula who had cardiac surgery. At discharge, her discharge plan recommended that she follow up with rehab and support and a support group at the regional referral hospital, but no local resources were offered. And this, again, is the unfortunate aspect of discharge planners just not always having familiarity with those local rural communities. So she's discharged late on a snowy day. And once home and settled in a little bit, her husband developed her cardiac rehab program from information that he found on the internet because travel to the discharged hospital to do that rehab was unrealistic. It was only later that the patient learned that her local community access hospital had a cardiac rehab program of which the discharge planner and she and her husband were not familiar. So the goal of our project has been to improve health outcomes and reduce rehospitalizations of patients discharged from regional hospitals to small towns and rural communities by enhancing the discharge planning and rural transitions process. And for this, we've taken a patient-centered approach as funded through the Patient-Centered Outcome Research Institute. Historically, most medical and health systems researchers conducted their work from the systems perspective, the perspective of the provider. The PCORI method focuses on a patient's goals, needs, and preferences from their own patient perspective. We also focus on functional outcomes, getting the patients back to their daily routines, rather than treatment delivery measures alone. Our three primary activities involve systematically integrating the patient voice into the research process, mapping the patient perspective onto the system perspective, and integrating the perspectives of other stakeholders. And with that, I'm going to turn this over to Heidi, who's going to tell us more about the context and the program.
Okay, first I'd like to give you a little bit of information about Missoula and St. Patrick Hospital, which is a regional referral hospital we will be referring to throughout the study. St. Patrick Hospital in Missoula, Montana serves much of 12 counties in western Montana that cover an area of 29,918 square miles with a population of 341,096. This equates to a population of 11.4 persons per square mile. This compares to Washington, D.C., which has a population of 658,000, living within 61 square miles for a density of 9,856 persons per square mile. While some communities in the region, such as Missoula, have dense services, others lack many services that urban counterparts have come to expect. These include both medical resources, such as cardiac rehabilitation, and community resources, such as public transportation. We are working with the patients coming from and returning to one of the 4 more rural counties in the Missoula Hospital Referral Region. Our local partners are critical access hospitals in Beaverhead, Lake, Powell, and Sanders counties. These counties are quite rural, and some qualify as frontier, with populations that range from 2 to 9 per people per square mile. Again, this compares to Washington, D.C., which has a population of 9,856 persons per square mile. Residents from Beaverhead, Lake, Powell, and Sanders County have quite low annual household incomes, ranging from a low of about $26,000 to a high average of $30,000 per year. And this is household income, not per person income. Travel distance and time to Missoula is also significant for these residents, ranging from 1 to 3 hours commute, and this is one way. We are conducting our research in 3 phases. In phase 1, we've developed a rural patient-centered research and development agenda. In phase 2, we've used the results from phase 1 to develop an enhanced discharge planning and rural transitions model that addresses the patient perspective. We have completed these phases and are now in phase 3, which we will begin to experimentally evaluate the comparative effectiveness of the enhanced rural transition model. This slide presents a few selected findings from phase 1, creating a patient-centered research and development agenda. For example, we found that the regional referral hospital, St. Patrick Hospital, discharge planners are stretched for time and are often unaware of rural community resources. Local primary care providers the local meaning the rural and frontier providers, are often unaware that their patients have been hospitalized. Of the 514 patient respondents to our survey, 66% had one hospitalization at St. Patrick Hospital, and 34% had two or more, with 40% having an additional hospitalizations elsewhere, say at their local critical access hospital. The survey also found high levels of satisfaction within the treatment inside the hospital. So we found that patients were happy with the care they received while being hospitalized. The Concerns Report Method survey we conducted is structured to create an agenda of strengths and problems from the patient's perspective. The actual patient agenda is shown in this image. Most significant problems involved getting rehabilitation services locally, negotiating payments with providers, dealing with gaps in services, and getting local follow-up. We use these findings to set an agenda for a series of community focus groups with patients, providers, and other stakeholders. Participants told us the characteristics and features of a desired model for enhanced discharge and rural transition planning. These include: build on the strengths of the treatment and the services that are already available locally, be simple and efficient, improve organization and efficiency, if nothing else, add a local coordinator to facilitate transitions home, include early notification and involvement of local providers, incorporate a local transition conference to finalize transition plans using local resources to meet transition needs, and finally complete the transitions to the natural systems of support. To guide the design of the proposed intervention, we adopted a rudimentary transitions framework. This figure depicts our basic framework as involving a patient's transition from hospital to home in a small town or rural community. Importantly, it also involves transitions from dependence to independence. This parallels a transition from acute medical care to routine activities in a natural systems of support. This framework led to the specification of a basic rural transition model. At the bottom, this model involves the transition from a regional referral hospital to a small town or rural community. This transition involves a shift in support from the patient, from a discharge planner on the left to a local community transition coordinator on the right. These two provide key supports to the patient during discharge planning and the transition back home. In our model, this shift is facilitated by an electronic medical record summary of care. In our setting, this is located in an EPIC, episode of care encounter, created specifically for this study. So the basic model of enhanced discharge planning and rural transitions. This algorithm more specifically translates from left to right: admission to the rural regional hospital, early notification of the local community transition coordinator to engage local providers and resources, conduct a transition needs assessment, and develop a patient transition agenda. After discharge, there are three major steps performed by the local community transition coordinator, including a transitions home conference, organization of a local services and supports needed, and shifting resources to provided support for a patient's long-term goals. Again, this process is facilitated through an electronic medical record summary of care. We worked with a wide range of stakeholders to describe the roles and responsibility of key actors in detail. The important message in this figure is that it shows the number of actors and stages that need to be coordinated in order to promote a smooth transition. It also highlights in the center column the new role of a local community transition coordinator. And this person works in the rural or frontier county where the patient came from. We have worked to specify this new role of the local community transition coordinator particularly. This person has responsibilities in 4 areas: including establishing connection with the discharge planner and patient, coordinate local support, support patients' transitions to natural systems of support, and organize and build rural community infrastructure. We have developed and are evaluating 5 tools hospital staff and community agencies can use to operationalize this model, including a detailed procedure manual using a personalized system of instruction, a tablet application for the research discharge planner to use in conducting a patient-centered needs assessment and developing the patient transition agenda, a tablet application for the local county community transition coordinator to use in assessing the patient's long-range goals and launching them back into their natural systems of support, a model of community resource bank that lists all relative community resources and links the patient's needs and goals through the 2 apps, and finally, an electronic medical record platform for integrating providers and information into an electronic episode of care summary of care that conveys the patient's story over time. The Patient-Centered Needs Assessment provides a standardized assessment process for all patients. This is a needs-based rather than a risk-based approach. It assesses needs in 17 areas ranging from housing and transportation to rehabilitation and wellness. It generates a patient's transition agenda and a draft plan by linking a patient's expressed needs to locally available resources in their hometown. It is shared with the local community transition coordinator and the local primary care provider through an electronic medical record episode of care. Needs are assessed in a way that provides some basic patient education and with a framework of motivational interviewing. So for example, the research transition coordinator asks the patient to rate their level of confidence about each of the 17 areas of need. In this case, the research transition coordinator would say to the patient, a safe and comfortable place to live contributes to your healing and recovery from treatment. How confident are you that you have a safe and comfortable place to live when you leave the hospital? If the patient rates their confidence as low, then there's a consequence analysis that would go like this. If you lack a safe and place to live while you recover, you may experience a relapse or may not heal as fast or as well as you can. Is this an area you might like some help? If the patient says yes and agrees, the item is added to the patient's transition agenda and linked to locally available resources relevant to the identified need, such as safe place to live, maybe family, friends, neighbors, a church, Summit Healthcare, independent living, or a resource such as Epic. A home health agency, if one is available, is included in the resource bank. The patient's transitions agenda is uploaded into the electronic medical record. The local community transition coordinator is notified of the posting of the patient's transition agenda and begins working to draft a rural transitions plan while the patient is still in the hospital. So all this is happening while the patient is still in the hospital, the needs assessment, and then the transitions plan. When the patient returns home, the local community transition coordinator holds a conference with the patient. The local community transition coordinator uses the patient's transition agenda to guide in the discussion of a patient's preference and to finalize the local transitions plan with the patient. This includes helping the patient choose local supports and providers, specifying the steps the patient needs to take to engage in those supports, assigns responsibility for who's responsible for the steps, and also tracks the progress. The intent of the transition plan is to provide needed support that will maximize recovery and minimize rehospitalization. This involves providing support for the patient as he or she moves from dependence to independence. While this can best be treated as a continuum, we have accepted that in general, the local community transition coordinator can work with the patient for up to 30 days. This is a point set by policy. As such, when the patient has achieved their transition objectives or at least 30 days post-discharge, the local community transition coordinator will typically bring her services to a close. But the patient continues on their trajectory to re-engaging in meaningful life activities. In recognition of the transition continuum, the local community transition coordinator can conduct a brief assessment of a patient's long-term goals and their confidence in achieving those goals. As with the needs assessment, for those areas in which the patient lacks confidence, the local community transition coordinator can link or refer the patient to other local resources that may provide services or supports that would help the patient achieve those goals. So now we're talking about long-term goals for the patient. Finally, each community presents a unique context for health. That context includes the physical, architectural, and social environment. The better organized the community, the more likely patients are to avoid illness and injury, and when treated medically, the more likely the patient is to recover without being rehospitalized. As such, the local community transition coordinator has another role: organizing and building rural community resources and infrastructure to help promote population health. And now I'll hand it over to Dr. Joseph Knapp.
Well, thank you all for being online today, and especially for those of you on the East Coast. My condolences as you get hammered with this, sounds like a mega snowstorm. I'm a cardiologist in Western Montana. I've been here now for some 30 years, and I'll give you my background is the impetus as to why we got into this particular project from the get-go. Some 4 years ago, our cardiovascular group was identified as having the lowest readmission rates for congestive heart failure in the country. The hospital institution that had the lowest readmission rates for congestive heart failure. And we did not have a clue as to why that was occurring. And so it led us to an introspective review of how we cared for people with advanced heart failure. And when we looked at all of our internal processes and internal performance, they were exemplary. But what we came to realize is we had no understanding at all of what happened to people after they left our institution and returned to their communities. And as Craig mentioned earlier, some half to two-thirds of the population of our hospital come from counties other than the county that we reside in, and in many of them an hour or 2 or 3 or even 4 hours away from where we are. So these were folks with advanced heart conditions who were returning to their communities after a successful hospitalization with very little arranged continuity of care going forward. We all live in a world of acronyms nowadays, and all of us know, and I'm going to talk about 3 specific acronyms which I think are really important to all of us as we move forward. One of them is the Accountable Care Act, which is also is used kind of in a layman's term of Obamacare. It has really revolutionized in many ways the availability, or the accessibility, I should say, of care for people. We've had countless millions of folks who previously had no access to health care who now have insurance, which is allowing them at least a potential or theoretical access to a healthcare system. We have a healthcare system that really has not stepped up to the plate to be able to respond to the potential implications of a population that has expanded potential access to them. Second thing is that those of us who reside in the rural environment, and it was quite a pleasure to see that nearly 90% of the people on this call are from rural environments, struggle with the ability to care for the people that we have in our populations as a stand. As I tell individuals that I speak with all over the country, that the problem with rural care isn't competition at all. Our problem is survival. It's really trying to be able to provide the care that we know we should be providing to the populations we care for. And going forward, we're going to be challenged by an expanding population who want care and less of what I would call classic or traditional care infrastructure to provide for those services. And again, for all of you who reside in rural America, you know what I'm talking about when I say you've got to be extraordinarily creative when it comes to providing care from people after they leave your respective institutions. And so as part of this process, what we've done here in Western Montana is team up the medical industry, which is me, and our academic industry, which is the University of Montana, and the Rural Institute in particular here at the University of Montana, to look at how we can take a very challenging environment and expand upon providing services that we dearly want to provide and patients dearly want to receive. One of the things that's really quite clear to me in working in rural America is that all of us have to act at a heightened level of our capabilities. We call it a compression of care. Simply put, that people who are in my position as clinicians have to really act at our highest level of capability, and up and down the road, each and every one of us can't afford to waste our talents, because we just don't have enough of a talent pool to go around. So while we can't expand our own internal clinical talents, we have to avail ourselves of what I would consider non-traditional talents in our local communities, be they social service agencies, be they community agencies, religious agencies, many of the agencies that are not typically considered to be healthcare agencies as part of the care processes going forward. There are being developed, and it will eventually arrive in a community near you, accountable care organizations, which are tasked with providing care based upon the triple aim of quality, affordability, and satisfaction to the patients, care in kind of a new age, because we're going to see more and more stresses and strains upon the cost issues of healthcare. And then finally, what we've learned in dealing with this project from this patient-centered outcomes research institute funding source, that we're really going to start having to look at the care we provide from a very different perspective, that not solely of healthcare practitioners or providers, but really more from the standpoint of the populations that we serve. So many of the metrics that we use in caring for people have to do with outcomes from our perspective or costs from our perspective, when realistically the entire premise behind healthcare is not our perspective, but the perspective of the patients and the people we serve, and the quality of life that they engender as a result of the interaction that we have with them. So this is kind of a nuanced but very important distinction in the way we look at the kind of care we provide. We can't simply measure our outcomes on how we perceive our outcomes, but really has to be from the standpoint of the people we serve and their needs, wants, and desires. So we're moving, I think, from an old traditional model of providing care to a much differentiated model of care that really is way more holistic than it appeared when I entered this profession some 30 years ago. That means we're all going to be having to look at who we are and how we interact and what our responsibilities are in an entirely new and different fashion, still in the very struggling and challenging environment of rural care, where resources are limited and the populations are distinct and different than those who reside in the more urban environments. So with that, I'm going to bring this discussion to an end. And Misty, should we turn it over to questions now?
Yes, if I can find my mute button and get it off. Thank you so much, Dr. Knapp, and also for Craig and Heidi. Do put any questions you have in the Q&A box or into the chat box. We have several questions we already have, but please keep them coming. I'm going to go ahead and start bringing up some of those. I just got another one in. So the first question is, do you use a real-time notification system from an HIE, which is a Health Information Exchange, to help coordinate the early and proactive care management? And I'll throw that on. I'm not sure which one of you would like to answer that.
So we are not using a health information exchange, and the reason is the 4 critical access hospitals that we are working with, that the local community transition coordinator is housed out of, are all on our EPIC electronic medical record system. So we can easily go in and just send them a message in their in-basket. They get the patient, all the patient's name and everything just pops up because we are all connected to EPIC for our electronic medical record. Now, we are going to work with some outlying providers that when the patient follows up will not be on EPIC. And our plan of attack for that group is we will contact the physician's office at the follow-up visit and probably, you know, do whatever they generally do, but I'm guessing it will be faxing. Probably faxing, and this is very, very rural area where this office, you know, may have an electronic medical record system, but we aren't able to get into it, but maybe does not even have that yet. So, so no, we're not using the exchange for this study.
Yeah, this is Joe. In the design of this particular project, we explicitly wanted to eliminate the issue of data accessibility, clinical data accessibility. So from the get-go, we limited our referral hospitals, the outlying critical access hospitals, to those that were already on this EPIC data network from the get-go. We figured that was such a confounding issue from the get-go that we didn't want to go down that path. We wanted to look at things other than the data accessibility issues. We really wanted to look more at infrastructure issues, services in the communities, other than are you linked electronically.
And as we go forward, I mean, we are still so far away with having interconnected and operable systems to be able to provide health secured information. You don't have to be in a rural situation. You can still be in, you know, even in Pennsylvania, we have a lot of issues. And home health agencies typically are not players that usually are involved in health information exchanges unless they are a partner or part of a larger facility. But there is, you know, faxing, but the consistency of the information, I think, Heidi, some of the slides that you covered, I thought were excellent, and about providing exactly who's responsible, the patient responsibility as in the key actors. Once you've designated those and set those up as a basic framework, no matter what systems you use, you know, faxing can provide that same information, you know, just in a little less advanced technology, but the information's still getting there. I have another question. Is the local coordinator funded by the regional hospital or health provider or local health alliance?
The local community transition coordinator is funded by our contract with the local community access hospital. So we have contracts with those 4 hospitals, and inside that contract funds the local community transition coordinator, and that person is housed locally, but they're housed actually out of the critical access hospital, so they have access to EPIC and medical records and the system as well.
Great. And throwing in another, you know, so that is being funded within your project. But, you know, if you're not involved with a project, I, you know, really highly encourage reaching out to the local hospitals that the hospitals where your patients are going to, the 1 to 4 hours away, and ask if they're doing any type of care transitions program. There are care transitions programs that are all over the United States. That work has been being done since back in well before 2005, but there are many models of care out there. Dr. Naylor's model out of the University of Penn, Dr. Coleman's model out of the University of Colorado, and there are many, many more, and many models that have been selected from those or are merged together. So many organizations are doing care transitions, and one of the things that they have found over the last 6 to 8 years is who's going to pay for that coach, or who's going to pay for the coordinator. And they've really, a lot of the organizations have gone outside of the box. They've looked at working with your area on aging, and they're including that as part of their work that they're doing anyway, and they're working and communicating together. Hospitals have stepped up, especially when you would look at larger hospitals that are trying to reach the communities that, I mean, I think that what Dr. Knapp had said about 2/3 of your patients were 1 to 4 hours away. So, for hospitals, and talking about a collaboration and working together, it's really a good starting point to talk with them to see if they are able to include that as part of the discharge planning, but setting up a very formal process.
Yeah, this is Joe again. Just from a cost standpoint, because of the issues with readmission rates or readmissions to hospitals, third-day readmissions, and the potential costs to the institutions, we have not, but it would be a very worthwhile endeavor to look at the potential impact of this kind of a role on, and it actually is part of our study here, to look at readmission rates, because I honestly, fervently believe that the effect of this type of a person, these kinds of coordinators, on readmission rates, when you could look at the cost of the individual in an outlying hospital versus the cost to the referring institutions of readmission, the potential savings can be extraordinary. We actually have one of our 4 critical access hospitals that values it to the point that they have actually considered funding an individual from their community. This is a hospital, it's 100 plus miles from our referral center, actually affording a in-house coordinator, not at their institution, but at ours, to do this type of work, because the potential benefit to them from identifying people who can be served in their institution ongoing-wise, but also to decrease the readmission rates and therefore the potential liabilities to the institutions. It's not trivial. It's a potentially big financial ticket item to both institutions, the critical access hospitals, but also to our hospital as a referral center. Decreasing readmissions, unnecessary readmissions, remains a bane to the entire system, and these type of coordinators have the potential to be an extraordinarily powerful tool in accomplishing that, and hopefully we'll be able to demonstrate some of that in this trial.
Great. Those are really great points. And I really think the environment is very fertile for you to develop these relationships, and funding will, measures will come about because, of the reduction in payment that's currently going on for hospitals for, I think we're up to 6 or 7 diagnoses for readmissions now, but also that CMS has put out there by 2017 or 2018, 50% of payment for hospitals must come from a different model of care, such as the ACOs that one of you mentioned earlier, accountable care organizations, bundle payments, care transition models. I mean, there are lots of models that are going to be being developed that hospitals are going to be looking for. So they need to be able to reduce readmissions if it is adding to somebody's responsibility or adding a partner in a facility to be able to reduce those readmissions. Now they're going to be setting themselves up for a win-win as the healthcare continues to reform. Well, there were some more additional great questions. I mean, I think we could dialogue about this for a long time. Do you use the Patient Activation Measure tool, or what we know as PAMS tool?
Well, we're using the PAM 10. Is that?
that's the question.
Okay, so we are using the PAM-10 while the patient is still in the hospital as a measure prior to discharge. So we're collecting PAM-10 data on our baseline group and then on our intervention group, so we'll be able to compare. Yep.
Okay. And are you doing that more from a research perspective, or are you sharing that information with the home health agency or community services that are getting the patient to find out how actively and how activated that patient is?
You know, this is strictly from a research standpoint.
I thought, okay.
We enroll patients, they sign consents, and yeah. So this is
okay, that's what I thought. A lot of agencies and organizations are using the PAMS tool, you know, to determine how activated a patient is. Now, there is a licensing fee to use that, but some of the QIOs, or the quality improvement organizations, are getting some licenses. So you might want to reach out to your quality improvement organization and ask about the PAMS tool if they're going to be providing any licenses to try it, to test it. But there is also, I will give you a heads up, February the 2nd, February the 1st, we will be releasing from HHQI our patient self-management 2016 updated best practice intervention package. We do include a little bit of information about the PAMS tool, but we also have the Stanford tool and we have links and stuff in there that is free that also will help you determine about the efficacy or how much a patient is engaged. If you want to be able to utilize that, as well as lots of really good patient engagement tools or patient self-management tools and resources, because, again, we're in there on a short-term basis. We need to equip these patients to be able to manage their care independently, no matter the setting, but especially in rural environments, to help them to do some problem solving, determine emergencies, who and when they need to call. So look for that for February the 1st, the patient self-management best practice intervention package. And another question I have is, did you create a community dashboard?
Can you give an example of that, Misty?
I will ask Ken if you might be able to stick an example of that into the Q&A or into the chat, and we'll be able to follow up on that question. I'm assuming that perhaps a community dashboard where your other providers could see that, but it sounded like to me that you're using Epic just to transfer the information or have access to the same information. But let's see if Ken, you'll provide a little more information on that. And we also have another question in the meantime. Who is your model? Who in your model is the employer of the community transition coordinator, or did we already ask that? Well, sort of we did. I guess we did ask that. And what was your initial readmission rate compared to after implementation of this program?
Well, right now we're just implementing the intervention. So we have the design, but we're in phase 3. So we haven't compared prior to post because we're right in just beginning to launch the intervention.
Yeah, this is Joe. I want to comment upon readmission rates too, because I think I think some of these metrics are be careful what you wish for in looking at numbers, because I think that the tail is rarely as clear-cut in understanding things as possible. Oftentimes we look at readmission rates and 30-day mortality rates and others of these metrics as if they're directly related to the healthcare systems we provide. And so often what they end up being is not so much related to the healthcare systems we provide, services we provide, but to the communities and the environments in which people live. And let me give you an example. And we've already used the one of heart failure, for example. If you take our institution, we looked at this quite closely. We found that we had very low readmission rates for congestive heart failure. When we looked at the concomitant, which was 30-day mortalities for people admitted with heart failure, it was high. It was exceedingly high. And then as we looked regionally around us, this happens to be a commonality of the Pacific Northwest, that if you look throughout the Pacific Northwest, basically from Minnesota west and from Denver north, that in general, relative to national numbers, readmission rates for conditions like congestive heart failure are relatively low, but mortalities are relatively high. If you flip that coin and you look in urban Ohio, in particular in the Cleveland area, Cleveland Clinic area, 30-day readmission rates for congestive heart failure are outrageously high, and yet mortality rates are exceedingly low. Some of that is cultural, some of that is infrastructure, some of that is, I'm sure, demographic. I think one has to be very careful when you look at some of these metrics as to what they mean when you're looking at them. And I think you have to keep a very open mind in understanding all of these metrics. Keep in mind also that these are metrics that we look at from a healthcare system standpoint as if they're related to healthcare systems. And oftentimes they're not. Oftentimes they're related to the populations we treat, the environments we live in, the economies, the economic nature of the communities we serve, which is why I think we've got to get much broader in our understanding of what healthcare is all about and what it is we're trying to achieve here. So just be really careful when you look at these numbers.
And this is Craig Ravenslow. I would just follow that up and suggest that from the patient's perspective, the functional goals during recovery and then the longer-term goals are also associated with how people interface with the healthcare system. And so as we collected our data from patients, it was clear to us that we have to go beyond just looking at those healthcare metrics and think about what is it that the patients want and how are they working toward those long-term goals in ways that will help to reduce their use of healthcare services in the future. And I suspect from a home health perspective, some of you see this every day.
Very, very, very true. And when we talk about reducing admissions, we talk about those avoidable admissions. But, you know, when we're looking at our outcomes, or for home health, you're looking at star ratings and star reports, you know, they're looking at your percentage of readmissions, not avoidable readmissions. So I agree that we really do have to be aware of all of that information in the care that we're providing. But there is room for work, and thus the reason care transitions is a big intervention strategy for all settings, but that really can be impactful for this rural settings. Now, I do have some follow-up. Oh, yes, go ahead.
This is Joe. I want to make one other point because of the audience we've got here, which is predominantly a home health agency. For those of you who are not familiar with PCORI, or the Patient-Centered Outcomes Research Institute, I encourage you to go to their website and spend some time looking at what the implications of PCORI is. PCORI is I think, right down your strike zone from the standpoint of home health. The entire focus of PCORI is outcomes from the recipient's perspective, not outcomes from the clinical perspective, but from the recipient's perspective. It's an entirely different, nuanced way of thinking about care delivery, which I think lends itself extremely well to the area of home health and the more what I would call as a cardiologist, the more expanded or extensive, or even to the point of saying non-traditional ways of looking at healthcare. And so those of you who have not gone to their website, please do. I think there's a lot to learn. I think there's also a lot of opportunity from a resource and financing standpoint for people who are interested in this kind of work.
Great. Thank you so much. And I did put the website to the homepage in the chat box for you. I do have a little bit more follow-up question or information from Ken, and then we're going to move to the other slides and a couple other resources for everyone. But Ken has provided, let me get his original question. Have you created a community dashboard? And so he said, I envision something that sets a benchmark for the community, rates of insured, rates of ER utilization per 1,000, rates of hospitalization per 1,000, medical costs, rates of Medicaid, high school graduation, college graduates, residents with a livable wage, sorry.
Craig, I don't know, Craig, if you want to chime in, but we really don't have that kind of we didn't do that deep dive in those communities, and we have some statistics like we gave you of, you know, the population overall and the income, but we don't have, you know, the community assessments. We did look at each community. Each community does have an assessment on their community, and we did read those documents when we were learning about the communities.
And this is Craig. I may be misspeaking here a bit because this isn't my area of specialization, but I believe as we started this project, we were just coming to the place where the 5-year estimates that would get us down to a low enough level to look at some of these rural communities were just coming out for some of these places, at least with regard to some of our patient population that we're looking at. So we haven't done that, but I think it's in part due to some of the data that we had available. And I guess maybe I'm speaking from kind of a disability perspective, looking at those higher utilizers. But no, it's not something we put together to this point.
I will say, this is Joe responding a little differently. The 4 communities that we have linked to that have critical access hospitals are exceedingly different. One is has an extraordinarily sophisticated and fairly comprehensive medical community. That's one end of the spectrum. On the far other end of the spectrum, we have what I would consider to be Marcus Welby 1950s type medical care availability. And I think this is a very normal kind of the disparities that exist amongst some of the smaller rural communities are striking. And I think that's paralleled in their understanding of what their communities have, what their communities' needs are as well. It's an extraordinarily variable findings in the 4 different communities that we're interacting with. Not to disparage any of them, some of them are extraordinarily challenged financially and economically. Many, as Heidi mentioned, you know, these are communities with family incomes that I think all of us would agree are you know, well in lines with the lower, you know, quintile in the country. So these are very challenged communities, but some of them, like say one in particular, does have quite a robust medical community and a fair amount of infrastructure already built in, but it's quite variable.
Great. Well, we're going to go ahead and turn to the next slide, and actually a couple slides, so if we can kind of get our slides started again. Heidi, I'll let you change those, and you might have to wiggle a little bit. Thank you. Go ahead and change to some resources, but I'm going to throw in kind of a comment that Dr. Knapp made. I'm going to throw a resource into the chat box. I love the comment that you mentioned about we have to work at our highest level of capability, and that starts from the physicians all the way down. And we have to maximize each of our disciplines. We need to have care coordination, that we're not making visits the same days when we're driving so many miles. We can have our therapists, our aides, doing assessments and providing feedback for us. Obviously, we can use telehealth, we can use phone monitoring, lots of other techniques as well. We have an upcoming cardio land call. It's related to cardiovascular, and I'm going to put a posting to a flyer for it. It's in March. I just put it in chat. It's for the 17th of March from 2 to 3. No, actually, it is a 2-hour from 2 to 4 p.m. It is going to be a presentation talking about exercising and leveraging therapy, physical therapists into congestive heart failure or heart failure treatment. We have 2 nationally known therapists that are going to be presenting. We'll also be providing some tools and resources within that 2-hour period. We are also attaching that webinar, either live or recorded, within an e-learn in our HHQI University. We're going to add some reflective questions and an evaluation. Basically, that's all. And we will be providing nursing CEs for that, and we have applied for physical therapy CCUs for that would be available to be used in I think, 23 or 25 states. So there is information in the flyer. If you have questions, follow up with the mailbox about it. But the information will be great to leverage therapy to help with heart failure. Some additional resources are some of our archived webinars for underserved populations. I picked some, there are many, many more. I picked the ones to put on this slide to show you those that would really relate to this population. And so next slide, please. And with our next slide, it is our underserved population best practice intervention package is a primary package, provides a ton of information and resources on looking at underserved regions, looking at the dual eligible populations, small home health agencies, and so if you're rural, you may fit in that category as well, and also health disparities. We also have a newsletter, an update newsletter that comes out every quarter. You can sign up for that if you haven't already, and the updated issue for December is related to rural health. I think you might find that interesting. Next slide. And we're going to be wrapping up here. We have lots of courses in the university to be able to do a care transition project. You know, it's wonderful that they're working with University of Montana and a variety of the critical access hospitals and putting together a wonderful collaborative. If you're not able to do that, you can still work on creating a quality assurance and a performance improvement plan, which is going to be a requirement with the changes in the conditions of participation. They're still in draft. We're still waiting for final ruling. But as of January the 4th, we now have 4 courses that are provided in our university. They're all free. We have tools and resources to help you develop quality improvement projects, and you could relate this around care transition, and there's tons of resources for care transitions on our website. You can do it on reducing hospitalizations, med management, and cardiovascular health are the current performance improvement projects that we have resources and tools to get you started. Next slide. I think that's just kind of how to connect with us, and we are at the top of the hour. I thank everyone, especially our presenters and the work that they are doing and willing to share with all of us. I hope each of you have been able to take away some information. There is an evaluation that's being provided as you leave. Do provide some other topics of information you're interested in and would be able to help provide those in future underserved population network calls. So with that, thank you very much. Stay safe and stay warm.